Hello, everyone. I see everyone trickling in. We have a ton of people on today, which is amazing. It's going to be a really good webinar. And let's see, 500 of you so far. Welcome. We're so happy to have you here. I'm Sharon Allen, Director of Client Success for CE Zoom and Zoom Education. And I want to go over a couple housekeeping items really quickly so that we all have a good experience. For those of you new to this process or who haven't taken a webinar from CariFree Cooperative or CE Zoom before, I'm going to go over a few things. This is a 1 hour, 1 CE course. At the conclusion of the presentation and the Q&A, we will display a verification slide, and this will have a code on it. So after this course happens, please take that verification code, log into your CE Zoom account, and click the green verify button that's next to this course in your dashboard. That green verify button will not be there until after the course happens. So, so don't look for it yet. Wait till after the course happens. So once you log into your account, you're on your dashboard, you're going to enter your verification code, take a short survey, and when your attendance is confirmed by the CariFree Cooperative, your CE certificate will be in your records on your CE Zoom dashboard. For any problems with your CE Zoom account, you can please visit support.cezoom.com and check out the articles there or submit a ticket. So now I'm going to turn the time over to Jenny.
Thank you, Sharon. And thank you everyone for attending today's webinar. I know there's some crazy weather across our country right now, so I appreciate everyone taking the time to attend today's webinar, and I hope you're all staying safe. We're definitely excited to have you with us. This webinar is sponsored by the CariFree Cooperative, and the CariFree Cooperative was started by CariFree as a way to bring together like-minded dental professionals who work together to further the message of risk assessment, preventive dentistry, oral and overall health and wellness. Today, our presenters are members of this cooperative. They are Dr. Kim Kutsch and Dr. Doug Thompson. I will pass it off to Laura now to introduce Dr. Thompson.
Thank you, Jenny. It is my pleasure to introduce to everyone today Dr. Doug Thompson. Dr. Thompson believes in a treatment model that brings dental health practitioners and medical providers together for a total body healthcare approach for his patients. He employs advanced DNA bacterial testing methods and other leading edge dental science to enable early risk assessment and personalized treatment planning. Among other topics, he coaches on risk assessment, treatment planning, digital photography, and systems to transform traditional hygiene services into value-added, personalized periodontal medicine. We want to give a huge thank you and welcome to Dr. Doug Thompson. Thank you so much for being here today. And then Jenny, I think you have someone else to introduce.
I do. Thank you, Laura. So also joining us is a man who needs no introduction, Dr. Kim Kutsch. Dr. Kutsch is a retired dentist of 40 years. He is a prolific writer, thought leader, inventor, and researcher in the field of dental caries and minimally invasive dentistry. He acts as a reviewer of the Journal of the American Dental Association and Compendium. Dr. Kutsch is the CEO and founder of Dental Alliance Holdings, the manufacturers of the CariFree system, and is a scientific advisor of dental caries at the prestigious Kutsch Center. We are so fortunate to have him as our fearless leader. So please help me in welcoming Dr. Kutsch.
Hey, thank you, Jenny. And I just want to really give a shout out to everybody that's online today. I thank you for spending your time with us. Doug and I go back 20 years. We met at the Kutsch Continuum as we were taking that program together. And Doug is a very humble guy, and I will tell you that he has more clinical data on patients and the medical approach to treating periodontal disease, documented cases longitudinally than anybody that I know of. And he also established the Wellness Dentistry Network.com, which is one of the greatest resources I've ever seen when it comes to systemic health and periodontal disease. So it is just my extreme pleasure to have you here today, Doug.
Thanks so much, Kim. Appreciate it. I'm going to go ahead and get started with the program. And so I'll move right into the presentation. This presentation is it's a sister to one that I did earlier that's on the CariFree website that you can look at. And it was the beginning of the disinfection protocol. And I had to learn a long time ago how to get patients well and keep patients well. And so we created a program called Disinfection Strategies at Work. There's a lot of different ideas out there about what to do. And we really have hit on something that's been working really well for us. So what I want to make sure everybody understands as we get into this is that this periodontal disease starts with a challenge from a group of microbes. And that microbes are made up of bacteria, yeast, and viruses. And what happens to those microbes is they stimulate this unique thing that we all have called the host immunoinflammatory response. And it's made up of our genetics, obviously things we can't change, and then a lot of things we can change. Our environmental input, like smoking, how much sleep we get, rest, nutrition, that kind of thing. And if this disease stimulates that host response and that host response doesn't over exaggerate a response, then this disease stays confined to the gum tissues. It's called gingivitis, which basically it's some red tissue. However, if this host immunoinflammatory response goes haywire and it continues to work and work and work, we will get a dysregulation of bone metabolism, and we have a thing called periodontitis. And I can tell you this is a medical disease with a dental solution, and only dentists can be really are the ones that can take care of this, and that's the idea. So I want to make sure, like caries, this is a biofilm induced disease, but it's host modulated. So it's modulated by the host. And we're going to talk about host modulation after we get a couple more things nailed down about the disease process. In our particular practice, we mandate certain pieces of diagnostic data so we can make a diagnosis. And these diagnostic data is going to be a perio chart with recession, pocket depth, bleeding. We're going to classify the disease, stage and grade it. We're going to look at what modifies the disease, called a risk modifier form. And then we're going to look at the microbes and genetics. And we do this for all of our diseased patients. And our hygiene team does this daily. And we just did it in the operatory just before we came on today with a new patient. So a clear understanding of the disease, all you really have to do is know this slide. There's two main things that determine what happens with this disease: the microbiome composition, what it's made up of, and how you might respond to it, the host modifying factors. So these are the two things you must know, and you should evaluate both of these before you start to treat the disease. Why? It'll change your treatment outcome. It'll change your treatment approach, and it's really what you should be thinking about doing. Now, there's many different companies that you can use now to test the biofilm or to get some representative idea of what's going on. Are these telling you the whole story? Absolutely not. But they tell you a big piece of the picture, and we use these to help guide our therapy. We use these to help educate the patient. We use these to check our work. We use these in a number of ways. And if you're going to get into the medical side, we use these to look at how this disease could affect Alzheimer's, dementia, vascular biology, that whole piece. And this is what we're continuing to talk about both at the Coy Center and the Wellness Dentistry Network, and on any of these webinars are all putting all these pieces together. Why is it important? It's important because this disease process is now related to 57 cross-reference diseases. And we know that if you have the bugs and you have the viruses and the yeast that create this disease response, you could have a huge impact on systemic health. And that's really where our big opportunity is having people be healthier and get healthier. Here's what we need to understand. If you look at the graph on the left, this is a healthy person. And when you look at the periodontis associated species inside the healthy biofilm, it only makes up 5%. So literally 5% of the bacteria in a normal person's mouth is going to be periodontitis producing. So they're there in health. However, look what happens when we get disease. When we get disease, the periodontitis species outpaces all the other species, and about 50% of the biofilm becomes made up of the periodontitis species, whatever that group is. Now, what do we call that? In dentistry and in oral health, we call it a dysbiosis. If you look at Kim's first book called Balance, that was the idea. When you get out of balance, you get this dysbiosis. And I can tell you, whether it's healthy or whether it's a dysbiosis, it wants to be resistant to change. So something's got to really move it. And what we've been doing in periodontal management is we've been trying to move it with a scaler alone. And I can tell you it's not enough. It's just not enough. So we want to shift the biofilm and we want to shift it back to a state of health. So I use these metrics. I use these different tests to help tell me. Some of these tests just give me graphic representation of a logarithmic concentration of certain bacteria, whether they're there, how prominent they are. These metrics. Other companies will give you a composite score. So you'll see a numerical number that represents biofilm load. Whatever one of these you use the same one in the beginning, use the same one to check your work as you're moving along and at the end. That's the idea. And it works beautifully. So what's the goal? The goal in therapy is really simple. We want to get rid of the pathogenic microorganisms, and we want to we want to use mechanical debridement and chemotherapeutics. And we want to get rid of the pathogenic microorganisms, and we want to either eradicate, suppress, or alter this combination of bacteria, yeast and viruses, so that it doesn't stimulate the host immunoinflammatory response in a way that causes disease. That's the idea, and that's the goal. And this was written really clearly in a 2012 paper by Jorgen Slotz. And if you haven't looked at this paper, it's still timeless, and everything in that paper holds true. So you could go back and look at that paper. So what did we do? We developed a very strong disinfection protocol around this system, around this idea, and it's well written out. This is part of our network materials that we use to guide the basic process. And this is our basic disinfection protocol. Now, this is what I went over last time when we were on this webinar series. So in my practice, how do we know if we're successful? I can tell you we need to have 0 areas of line bleeding on periodontal charting, and you must change the microbial profile. And if you don't do both, then you're not home. You're just not there. And we have methodologies to help do both. And it's hard. I can tell you it's hard. It's harder than you think. Now, why did I pick 0 bleeding on probing? 0 bleeding on probing is a small number. And can you really get there? Here's what the problem is in periodontal medicine. If you want to determine if someone's going to break down or not, you have to look at them over a series of appointments and see if the same area is bleeding, measure. It could take a year to 2 years. I'm not doing that because this study, this particular paper written by Nicholas Lang looking at periodontal health says that there's a high negative predictive value, nearly 100%, 98, 99%, meaning that if you have no bleeding, it's very predictive that this is not going to break down. So 0 bleeding on probing is almost 100% predictive that you're not going to have breakdown. Now, it's not perfect. You'll have a few people still break down with no bleeding, but not many. So the idea is bleeding on probing is something that really can be used well. And if you have patients that continue to bleed on probing, they looked at 445 in this paper, and over a 5-year period, these people continue to break down. So 0 bleeding on probing became our goal, and a changed microbial profile was the rest of what we wanted to do. So what's our clinical outcome? We have 2 goals, clinical outcome and a microbial outcome. So the clinical endpoints are we're going to get attachment gain. We want a reduction in pocket depth. We want 0 areas of bleeding on probing. We have many doctors send us cases and say, can you help me with this case? And they still have 15 areas of bleeding, 10 areas of bleeding, and it's 6 months into treatment. And they still have bleeding. They're not there yet. They have to do other things. And then what else do we want? We want no probing sites greater than 5, and we want only 4 sites. We want less than 4 sites greater than 5, no 5mm pockets if we can help it. And we want no 6mm pockets. There's no such thing as a healthy 6mm pocket. Why is that? Because it selects for more anaerobic bacteria, and it's not a healthy environment. What about the microbial outcome? Well, you saw the shift idea. The microbial outcome is we have to have this complex ecological shift. Now, the interesting thing is this shift doesn't happen unless you hit this disease hard and you hit the disease swiftly and you treat it in a compact time period. So doing scaling and root planing and having someone come back 3 months later, typically not going to be so successful. Doing scaling and root planing and doing repetitive care therapy, adding antibiotics, adding antimicrobials, many touches of the patient. A lot of our treatments, 6 appointments. It's gonna be much better and much more consistent. So what are we trying to do? We're trying to recolonize a new biofilm community. back to that one of health. That's really what we're trying to do. And so we want less than 4%, basically red complex species. So we don't want these red complex species. And this is a different paper. This information comes out of a paper by Magda Ferez. And this particular paper is 4.2%. And what I talked about during that webinar was the use of antibiotics, but I didn't maybe show the numbers of how significant the antibiotics are. And right now we have a dilemma in practice. We're being told that we shouldn't use antibiotics. Well, I can tell you that I can take patients that have periodontal disease. We can give them one look at an antibiotic and we can keep them stable for 10 years. So the idea is we want to use antibiotics prudently. We want to use it when necessary. And I think you're taking a lot off the table if you don't consider the use of antibiotics. That means we need to get comfortable using them. And then what about host modulation? What options do we have for host modulation? That's going to be the further questions that I want to answer, a couple common things that we can do. So why consider antibiotics? In the Magda Ferez paper, this is a great paper and it's on the screen. This will be recorded. So I know there's lots of information on the slides, but you'll be able to go back and look at it. But this paper is a great paper to look at because what she says conclusively is scaling and root planing is not going to get you home for most of your patients. And if you just do scaling and root planing alone, it doesn't cause a deep enough or a swift enough shift in the microbiome to get you always to where you want to be, especially long-term health. So we'll have people that say, yeah, they were good for a year. They were good for a year and a half. Then they disease reactivated. If you want to keep people stable for a long time, you got to shift that biofilm. So here's a couple studies on antibiotic use. And they looked at quite a few patients here at 3 months, 6 months, and 1 year. And they looked at patients that had scaling and root planing alone, and then those that had scaling and root planing with the combination, the empirical combination antibiotic, which would be metronidazole and amoxicillin. At 1 year, the number of pockets for each group was, they had 18 for the SRP group, pockets greater than 5. And many of these cases started with 25, 30 pockets of 5 millimeters or more. These were moderately diseased patients for sure. And then what about the group with combination metronidazole in addition to scaling and root planing? Only 5.3 pockets greater than 5. How about what percent of the group achieved our clinical endpoint? Our clinical endpoint. 61% for SRP alone, and 30% still had high risk profile, meaning pocket depth, some 6s maybe. They just didn't make it, but only 61%. How about for the group that had scaling, root planing, and combination antibiotics? 95% with metronidazole and amoxicillin. And how many had high risk profile for disease progression? No pockets over 5. So this is a great reminder of how much you're taking off the table if you don't have the courage and the skill to use the antibiotics and treat this disease. And then what about 1 year, those meeting the microbial endpoint? Less than 4.2% high risk pathogens and greater than 15% healthy related species. Well, in the SRP group, 32%, only 32% achieved that goal. But how about in the SRP plus the combination? 71%. And this is also something interesting that we see in the metrics in practice. And unless you're looking at the metrics, you wouldn't see it. But we see continual improvement when you combine these antibiotics. We continue to see reduced levels long-term, and these patients continue to get better over a year. And once they get stable and they learn what to do at home, they will be able to keep that new microbial community stable. And that's the idea. And so again, subjects that took the antibiotics continue to see a further reduction in deep sites 3 months to a year out. And we see that much, much less in SRP only patients. So, and this is what I've experienced in practice. So the primary goal of therapy, as a reminder, we got to get the environment free of the pathogenic microorganisms. If you're not looking at them, you don't even know it's there. So we really have to encourage you first to learn how to look at them, and we'll help you do that. And then mechanical debridement and pharmacotherapy are a must. What's our favorite? Well, our favorite disinfection product to use in conjunction with scaling and root planing for the oral cavity, in addition to antimicrobial care, is going to be our CariFree treatment rinse. And that's what I have pictured here. And we're going to use other things as well. But I can tell you, routine scaling, just routine scaling and polishing without the use of chemotherapeutics and other adjuncts is going to have little effect on this disease. And we've proved that conclusively. And here's what I overlooked in the beginning. If you look at this patient has, the top is his pre-treatment, and the top is his pre-treatment graph, and the bottom is his post-treatment graph. And what I ask people is, what do you see in the difference between these two graphics? And they will say, well, the bottom one has the same bacteria, like you can see the same columns of bacteria, but the concentration is a little bit less. Well, guess what his treatment was? I took out his denture. He doesn't have teeth. So guess where the bugs are? The bugs are on the denture, but they're also in the rest of the mouth. So if you're just scaling the teeth, if you're just curetaging the tissue in the sulcus, you're missing the tongue, the cheeks, the rest of the mouth. And the reality is these bacteria can live in the mouth for years. So think about this. If you have a mouth that's edentulated from periodontal disease, now you're going to put in $60,000 worth of implants. Be careful. I'd be doing microbial profiling on some of these patients. You'll see they have high pathogenic loads of bacteria, even with no teeth. So this area of our disinfection protocol is what we really are hitting hard with our SRP. In our office, this is about a 3.5 hour appointment. We do a total mouth disinfection. We can teach you how to split it up if you have to, but however you do this, it has to be done well to create this microbial shift. That's the idea. Now, in addition to this, first off, before I get into that, how long could I keep this that way if it shifted? So here's what I have. In 2009, I treated a patient. We treated him conventionally. This graph right here represents we got nowhere after conventional treatment, SRP alone. Then we added our combination pharmacotherapy, antibiotics. We caused a nice shift in the biofilm. Now the question was, from 2009, with just periodontal maintenance, how long could I keep that? How long could the patient keep that way? Believe me, I didn't do it. How long could the patient keep it that way? Well, let's just go out and take a quick look. This is 2 years, 2 months, 3 years, 4 months, 4 years, 6 years, 9 years post-treatment, 11 years post-treatment. He never had exposure, again, to the high-risk pathogens like he had in the beginning. This is an 11-year case. I have another 10-year case like this, and I've been doing this since about 2009, 2010. And so these diseases don't reactivate. Less than 4 areas of line bleeding, chart after chart, year after year, and we have the records for this, and we would love to show you how you could achieve these kinds of results. It's really, really fascinating. So one more component that we have to look at, because these risk modifiers help us determine our host modulatory options, and you'll get an understanding here in a minute. Risk modifier is a form that we use, and what we do is we look at and evaluate all the host modifying factors. One of the things that we just got done talking about a lot is the microbiome or biofilm composition and how we need to move this. But what about these host modifying factors? What about the stuff on the medical history, the dental history? What about the radiographic interpretation and the severity of past disease, prior bone loss? What about their lifestyle and other risk indicators? How would I put all that together and jumble it all up and try to make sense out of it? Well, we do it with what we call a risk modifier form. It's a checkbox form. And this is required every single time we do a bacteria study on a patient. We want to know what in their life could modify the risk. And I'm not going to get into that. We have a whole presentation on this particular concept. But the idea is this form represents what makes this box. It also represents what's in the acquired sector and in the innate sector to create this response. And why do I want to know that? Because we know now how to work on the biofilm quite well. But now I want to find out, how can we modulate the biofilm or how can we modulate the host to be even more resistant to the biofilm challenge? That's the idea. And this is where we're going now for the future. It's risk modification. And how do we do that? And in our practice, this form is designed to be filled out, and every single question gets answered with either a no or a checkbox on the form. And so here's what happens. As we get more checks on the form, and this goes back to 2011 now, this is a very old one, and you can see from the one prior, I'll just go back to it real quickly. You can see how much this has expanded just in 9 years. It's expanded a lot. There's many, many things we understand now that we didn't. But my original risk modifier form, what you do is you have these check boxes, and when you have these check boxes, the more you have, the harder this disease is going to be to manage. So you would say something like this. You would say, look, I took and we looked at all the things in your genetics and in your lifestyle that could affect this disease. And it helps us understand how your body responds to this unique microbial challenge. And we could change the microbes, but we could also change the way your body responds to the microbes. There's a couple things we could do. And what this form does is it lists these conditions or situations that might make the disease more complicated to treat. Maybe it's going to help realign our expectations for when we're going to get you better, that kind of thing, because it could take longer and it could be harder to control. The more risk modifiers you have, the harder this disease is going to be to control. And there's some things we can do to mitigate some of these risk factors. And that's what I want to talk about now. Another key point in periodontal therapy, which is really, really important. Any therapy that you provide that reduces inflammation is beneficial when you're treating a dysbiosis. And here's why. You know, when you have inflammation, you have increased capillary permeability, you have more food coming to the area, you have more fluid movement. The bacteria love that. So the idea is, if you can reduce the inflammation, it's going to create an environment less favorable for the pathogenic microorganisms to grow. And that's why in my practice, inflammation is a target of therapy, and inflammation is something that we have to control. If we go into the medical side, and we want to talk about that sometime, it's inflammation that drives many of these disease processes. That's why we want to take care of the inflammation. So let's look at host modulation. What does it mean? Host modulation is a concept where we actually alter the unique immune response that everybody has to the microbial challenge. And this is a very nice paper about host modulation therapy, and it outlines some of the different ways. Don't get bothered by the graphic. I'm going to make it hopefully easy. But what we're trying to do is make sure we understand that controlling inflammation limits the food supply. It will help reverse the dysbiosis. It will help promote periodontal stability. It's going to encourage periodontal healing. And again, it's going to be inflammatory resolving. And think about, when you look at some of these different processes that I'm going to outline, I believe in the next slide, you will see that many of these host modulatory options, some of these may still be in the experimental stage. So what I'm going to hit on are some of the common things that we can do that you might not be thinking about, that might make it a little bit easier for you to treat. So let's start with non-steroidal anti-inflammatory drugs. We know that non-steroidal anti-inflammatory drugs are anti-inflammatory. They block the inflammation pathway. They usually do that by limiting the production of prostaglandin E2. You would know these things like aspirin, Tylenol, and Motrin, some of these NSAIDs, and they can help in preventing some bone resorption, but there's a problem with them. I can't have a patient on them long term. I mean, there's some gut health issues, there's other things, although low dose aspirin has been shown to be safe, to be long-term. And what I would say about low-dose aspirin, I can't get into the total science about it, but low-dose aspirin in combination with omegas, that would be fish oil, has a potentiating effect, and that can be helpful. So most of your patients you should be looking at their omegas, making sure they're rich in omegas, and low-dose aspirin wouldn't be a bad idea. High-dose aspirin, probably not a good idea. What about sub-antimicrobial dose doxycycline? We know this as Periostat, and this is a 20 milligram Periostat tablet, And it's too small of an antimicrobial dose to be antimicrobial. That's not what it is. What they learned that it does is it blocks the production of some MMPs, and it blocks the production of collagenase. Collagenase is a collagen breakdown enhancer. And so if we could prevent the production of that, then it would save some collagen. Now, dentistry didn't use this so widely, so they picked it up in dermatology. They call it Oracea, and it's used in dermatology a lot. And I think that this is something that we should be doing more. And there's some great papers on the medical uses of sub-antimicrobial low-dose doxycycline. So anybody who smokes, aggressive breakdown, compromised immune system, any bone resorption issues, we should be thinking about this particular modality. We know that it also helps other parts of the periodontal fabric, and it's really a nice adjunct to help modify the host response. So we also know that you don't get the regular things that you get if you were taking high dose tetracycline. Like some people take it for Lyme, they take 250 twice a day, or 100 twice a day, or 3 times a day. These are higher doses. That's not what this does. And it will not alter the gut microbiota, and it will only prevent the production of these cytokines. And that's really a good deal. So interestingly, when they looked at and studied when they studied what happens in the diabetic patient, and they looked at severe perio breakdown in diabetes, they realized that the breakdown in most diabetics didn't come from just the bacteria, but it came from some breakdown or abnormality in collagen turnover. So we know that if you have type 2 diabetics, this would be a good strategy to use as an adjunct. Also, it also helps lower A1C. This is the Oracea that I talked about earlier for dermatology. If you have pemphigus, pemphigoid, some of these connective tissue disorders, osteopenia, even cardiovascular diseases, there's evidence to show it can be helpful. And again, it doesn't encourage the emergence of antibiotic-resistant pathogens, candida overgrowth. None of the side effects of antibiotics are attained. So how we prescribe this is 9 months on, 12 months off. And we do, or 9 months on, I'm sorry, 3 months off for a 12-month regimen. And where this came from was when they studied the low-dose doxycycline, they noticed that there was no real significant difference given at 9 months or given at 12 months. So that's where that came from. So again, this is the first MMP inhibitor that was approved for any disease in US and Canada by the FDA and the Canadian European agencies. And it does a lot. And if you look at bullet point number 14, it improves severity, probing depths, clinical attachment gain, bleeding on probing, bone loss. We're not using this enough, so we should think about this. Cuts down on some other biomarkers of inflammation, and like MMP9, IL-6, C-reactive protein. We just had a patient in with systemic IL-6 elevation and C-reactive protein, so we would be using some of these host modulatory opportunities. That's the idea. What about bisphosphonates? We have a bad problem with bisphosphonates, and that's the osteonecrosis of the jaw. So we really have shied away from it systemically. But here's what I want you to think about. Think about, could a bisphosphonate gel be used, maybe in a tray system? Could a statin gel be used in a tray system? So these are some more futuristic ideas that we're revisiting that might be able to be used. So don't just discount some of these things that could be topical adjuncts to help that might not have to be delivered systemically. That's the idea. Now, this is a very cool area that I really like, and these are called pro-resolvin mediators. I talked earlier about anti-inflammatory, non-steroidal anti-inflammatory drugs. Well, what about a thing called specialized pro-resolvin mediator? A resolvin is not something that's an anti-inflammatory. It's something that once the inflammation starts, it resolves it quicker. It's a resolvin, and it resolves it faster. And we have this now. And these resolvins, lipoxins, and protectins are made from omegas. So they're made from fish oil, healthy. And what they can do is they can help mediate inflammation resolution. That's what happens. They don't work on preventing inflammation. They work on resolving inflammation once it happens. And we have a product, SPM Active. This is from the Metagenics company. There's several other ones. Microbiome Labs has one, Designs for Health has one, and these are pro resolution mediators, and they are available for consumer use. And I'm using these when I get referrals from physicians and patients come in with elevated HSCRP. I'm looking at some of these host modulatory options. And again, what it does is it works on the resolution phase of the inflammation mechanism. And here's a graphic of what I would say. We eat these foods, and we eat these foods that provide omegas, and we get these essential fatty acids. And from these essential fatty acids, we get these anti-inflammatory molecules. And when you look at the diseases that these have been studied in, I mean, psoriasis, brain injuries, any kind of inflammatory disease, these help. So it's really a good idea for us to learn more in dentistry about these kinds of options, because it's out there for us. And these are things that we could do. And these are easy things that we could do now. This is something you just buy over the counter, prescribe 2 to 4 a day for the patient, and it will help them. And this is another, just a graphic of some of the company or some of the papers that have been done on looking at resolvins and protectins, these pro-resolvin mediators. But here's in a rabbit model, they studied inflammation-induced tissue loss, periodontitis, but brain injuries, lungs, cardiovascular health, eye health, kidney health. I mean, it's not uncommon in the medical world to start looking at using these in a variety of ways. Remember, periodontitis is a medical issue with a dental solution. So we need to be thinking about treating it more like a medical entity. And this is an idea to show you the difference between the initiation phase of inflammation and the resolution phase of inflammation. And this is where the omegagenics and this is where these products work. The SPMs work over here. So it's just a graphic to show that idea. And again, these are available and we can use them now. Now, these other modalities, anti-cytokine therapy, complement activation system, adaptive immune cell therapy, vaccinations. You know, we've tried vaccinations against Porphyromonas gingivalis, anti-aging approaches. Some of these we're not going to get into. We are going to look at a couple of lifestyle modifications, but we're not going to get into some of these just in the interest of time. So what about our diet? Because now we're talking a little bit about lifestyle. What about a high calorie diet from refined carbs? We know that that can produce oxidative stress. We know antioxidants can help us with that. We know fish oil can reduce inflammatory cytokines. We know curcumin or turmeric root is another host modulatory option. It's a supplement that's easy to take. 1,000 milligrams a day, simple. You can get it in multiple tablet forms. Everybody should be vitamin D optimized. You want to make sure everybody has adequate vitamin D. That's absolutely critical. And any other vitamin deficiency should be taken care of. So we know that looking at antioxidants, looking at nutrigenomics, we know we can change the host response to a bacterial insult. So this was a study that looked at an oral health optimized diet. What does that mean? It means low in carbs, makes sense already, rich in omega-3s for the obvious reasons that I mentioned earlier, rich in vitamin C and D. D-dole has to be optimized, and obviously fiber. Fiber is great for the gut, and fiber is great for a number of ways. We know that can reduce gingival bleeding. We know that can reduce inflammation. So yes, we talk to our perio patients about their diet and just give them some little tidbits. And what do we see? A huge reduction in bleeding on probing over a non-optimized diet. So this is the idea. And so don't discount the diet. And there's ways you can measure that. And I'm going to show you one of the ways we do that as well. And here's one other paper that has some interesting data about diet. Mediterranean diet. It would fit the above criteria. Low in carbs, rich in vitamin C and D, rich in omegas, high in fiber. This was an 8-week study, and it looked at significant decreases in PG, Previtola, Treponema denticola in the Mediterranean diet group. It also created an increase in a healthy bacteria that actually competed with PG. And the bottom line is even a Mediterranean diet can help reduce periodontal bacteria. maintain good oral balance and oral homeostasis, and it can help treat different diseases. So diet needs to be optimized for everybody that comes in with any kind of inflammation or any kind of disease. So we're going to look at Peter. He comes to me, and it's going to be a little bit brief, but we're going to look at Peter. And when you look at the radiographs, you can see he already has prior bone loss. That's the idea. If he has prior bone loss, that means his disease process went past that host immunoinflammatory response box, and he has a dysregulation of bone metabolism. Anybody that has radiographic bone loss could have more bone loss in the future because they've already had it. So we know they're at higher risk. He's 62, doesn't smoke. He quit a long time ago. But I get a lot of these patients that want to live as naturally as possible. I don't want to take any pills. I'm totally against all that. I'm healthy. I don't see a physician very often. You know, when these people come in and you start looking at them, many of these people aren't that healthy. So the idea is they think they are, but they're not that healthy. So he wanted his teeth cleaned. He hadn't had a cleaning. It was over 2 years ago. He notices when he brushes, his gums bleed. He has gum recession, doesn't do anything to clean in between the teeth. Thank God this guy doesn't have caries, because he did, and he just had periodontal disease. But, you know, like these patients, they think he's healthy. He's got a chronic bump that comes and goes on his upper right gum. Well, surely, you know, tooth number 3 is hopeless. And so they don't want x-rays. Anyways, what we want to think about is, what could we do for someone like this? What could we do for him? We start looking at his risk modifier form, and we start to educate him. This is a great education tool. Peter, you got quite a few things in your lifestyle and in your genetic system. You know, if you have a family history, you have a 35% chance of being much sicker and much more aggressive disease than if you don't have a family history. So that's just one thing. And we start to educate him. And pretty soon he says, okay, I'd like to do some things. Then we run a bacteria profile and we show it to him. And then we tell him what it means. And then we show him a perio-chart and we look at the pocket depths. And then he starts to get the picture. Maybe I'm not so healthy. Especially, Peter, this can affect 57 other diseases. So, I mean, it's serious. And you want to be healthy, right? You want to be as healthy as you can be. So we look at him and we start asking him, what would he do from a dietary standpoint? Well, he said, I don't know. I have a really good diet. So we have a PharmaNex scanner in the office, and that will allow you to look at antioxidants in the skin, the level of carotenoids, and it gives you some idea. I used to do SpectraCell, NutriVal. There's other tests you can do very easily. We can teach you about that to help evaluate nutrition. But we did the antioxidant skin score. His was quite low. And so we know he also had low vitamin D. He had elevated cardiovascular biomarkers because we did a measurement of those for him. And he snores, so could have sleep apnea. He wanted to have an implant replacement for that tooth number 3, high stress and depression. So he said he loves green tea. So here's just one example of how you could use something like a green tea supplement to help modulate the host. And so we used a product from PharmaNex, green tea, 18 cups of green tea in one capsule. So you're not going to have someone drink 18 cups of green tea. Oh, by the way, when someone tells you they don't need a probiotic because they take yogurt, you got to eat several containers, more than 30 containers of yogurt to get what you get in a probiotic. So yogurt's not a good probiotic for gut health. So why green tea? Well, in this particular paper, we looked again at an antioxidant-rich diet, vitamin E, vitamin C, vitamin A, and what we see is an inverse relationship between antioxidant load and disease. So we know these patients do better if they have high levels of antioxidants. Now, what about green tea? Well, that's what Peter liked. So that's why we put him on that supplement, just another way to modulate the host. It contains things that have a greater antioxidant benefit than vitamin C. We also know that the catechins in green tea inhibit P. gingivalis, P. intermedia, Previtola. That's nice. Inhibits collagenase. This is the same thing Periostat does, produced in the presence of P. gingivalis. And we know these green vegetables, berries, a lot of these things are rich in antioxidants and beneficial. But again, another confirming idea about host modulation. So as we think about reducing inflammation, we can look at diet, we can look at lifestyle, we can look at some host modulatory things that we can do pharmaceutically, supplements and other things, low dose doxycycline, and occasional use of short-term non-steroidal anti-inflammatory drugs. But again, diet and lifestyle are keys, part of the acquired component that contributes to that host immunoinflammatory response. And we know that we want to make sure people have good levels of antioxidants, and most of these things are going to come from plant compounds. And if you can supplement to it, but you're probably better off eating to it if you can. So plant compounds exhibit this anti-inflammatory, antimicrobial, anti-angiogenic activity. And again, whole grains, legumes, nuts, seeds. It's a great way to keep your immune system in good shape. So I want to just remind people that just a serving is a little bit in the palm of your hand, and it's not hard to do. A couple palmfuls of berries in the morning with some almonds, and a little bit of healthy grain, and it's really not too hard to do it. But we want to do this to make ourselves healthier. Now, what about other lifestyle factors? Critical components, sleep. That's huge for the immune system. Exercise. There's no pill. There's not one single pill you can buy or take that can give you the benefits of 25 minutes of exercise a day, even brisk walking. So get out and move a little bit. It makes a big difference. Hydration, mindfulness, staying connected, being well adjusted emotionally. This is really, really important. And we know today in this COVID world, this virus world, that when we have people with obesity, we have people with diabetes, and we have people with hypertension, not only are they most vulnerable to viral attack, but this chronic inflammatory response is an issue as well. So look for modifiable lifestyle factors in addition to things in the medical, dental history, radiographic interpretation, or your risk modification analysis that you can look at and explain to the patient why you'd want to use these other adjunctive ideas. So that's the idea. So Kim, I'd love to invite you back on. I'm sure there's probably, I know at one point there's over 800 people online. So I really want to thank everybody for taking time out on a Tuesday afternoon. But Kim, if we want to maybe field a couple questions, and I can stay around for a little bit longer if you need me to.
Yeah, thank you so much, Doug. That was very, very, very well done and very fascinating. And I think you pointed out a lot of things that we need to consider incorporating into our management of this disease. So many people are reluctant to use antibiotics, even the, sub-threshold dose, of doxycycline. But when you look at the evidence, I mean, the evidence is compelling. Right. So
no question. And what I didn't say, Kim, is I should tell our viewing audience that in my practice, working at this disease hard, it takes on average 4.5 months for my patients to get stable. So this disease is not treated in 6 weeks like we learned in school. And I mean, for some people it will be, but that's if you want to treat the masses, you're going to have some different disease control paradigm shifting for sure.
Yeah. Yeah, I think that's a really good point, Doug, because treating dental caries is the same thing. If you're trying to manage a biofilm disease and you're trying to shift the biofilm, and you also have some host modulation lifestyle issues that you need to shift as well, that doesn't happen overnight. When I started doing that, I thought, in 30 days, we'll turn people around, and it's like, yeah, it could be 6 months, it could be 2 years, in some of our studies where we saw continued improvement even after 2 years. So it's managing and treating biofilm disease are not easy. And that's why, dental caries and periodontologies are the two most common diseases in mankind. Yeah. And it takes time and, discipline, I think, to make that happen.
Yeah. And Kim, when you were looking at the CariFree product and you developed that product, didn't you work with some school children in maybe Australia or something, and you saw continued biofilm shifting for like a 2-year period or something like that?
Yeah, that's exactly right, Doug. We saw the biofilm continually shift for 2 years. And then after the third year, the study ran for 3 years. And during the third year, there was no additional improvement. But I mean, we were shocked because we really thought that, 4 to 6 months, we would have completed the work. And it continued to improve. So that really opened my mind to the possibility that, treating biofilm diseases is a lot more challenging than we all, I think, initially thought.
And this is where I had a hard time, Kim, with trying to help people learn how to do this. It was difficult. It's been difficult. And that's why we created the Wellness Dentistry Network, was to to put these resources so that people could chip away and learn at it. You know, you're not going to watch like a presentation like this and then just go and do a bunch of this stuff, but if it's videotaped, you can learn pieces of it. Your hygiene team can learn pieces of it. But this shifting, this biofilm shifting in that Magda Perez paper about systemic use of antibiotics, you know, we have to really encourage a complex shift that happens as quickly as possible, and in order to shift the biofilm. And so I just couldn't do it without the use of adjunctive chemotherapeutics. And 2009, when I saw the 2% sodium hypochlorite come on the market, I knew it'd be better than iodine. I knew it'd be better than hydrogen peroxide. I knew it'd be the best disinfectant agent that we have, and it's pH balanced, has xylitol and fluoride. I mean, it's the perfect adjunctive thing to use for perio management in the active disease phase, the active disease management phase. That's the idea. And I know you might not be so comfortable speaking to it for off-label use, but I surely am. So I have no problem with it.
Well, and you're not alone. I mean, there's a lot of people that, well, it's regularly used off-label to treat periodontal disease. You know, I think, Doug, one of the challenges we've got in society, we live in this, I want it now, and I think we're, everybody's in the 2-day shipping. We all go to Amazon and we expect everything to be delivered in 2 days. Well, I want to take this pill and have this fix that. I just want an instant solution for everything. And you look at biofilm diseases, and I think it's challenging and frustrating for us as practitioners, because it does take time and it is challenging, and there's a lot of factors. I mean, when you look at all the factors you even just presented today, and you just touched the top of the iceberg here in terms of all of the influences that we are now aware of, the pathways that interconnect in these diseases. It's like it's incredibly complex, and it takes time, and you have to be persistent, but you have to start doing it, right? At some point in time, you have to pull the trigger and go, okay, we're going to do it this way now. And because we know that what we know now is better than what we used to do. But I think that, we have to adapt the mindset that, this is not an overnight or, a 2-week process. This is like 4 months, 6 months, a year, 2 years. And patients, I think when you get into the behavioral management, it's 2 steps forward and 1 step back. I mean, that's right. The other challenge I think for us is we didn't ever really, we did scaling and root planing, done. You had a cavity, we put a filling, done. Right. And now we look, I mean, it was like we had the instant, treatment, and it really didn't. All it did was just treated a localized symptom, for today. But so you look at that it's going to take more time, and that just becomes more challenging.
Yeah, and I wanted to just let people know, I'm not going to. I'm going to Kim. Can we see everybody if I stop the screen share? Are you okay if I stop screen share right now?
Sure.
Yeah, I think what I really want people to know is, your journey to a wellness practice or trying to learn this modality it's a journey. It's not a single event. So the idea is not to put a presentation up that just overwhelms people, or, but it's to show the possibility and to look at what we're doing and what we're thinking. And the beautiful thing about periodontal disease management is it's doctor-led, but it's team-driven. So this is something that, you have hygienists and assistants in your practice that really want to be better, and they want to do better. And, nobody feels more guilty when a patient doesn't get better than the hygienist that's scaled and root planed for 3 hours. And then stuff doesn't happen. So I really think we have to look at this disease differently. We have to approach it a lot harder, a lot more succinctly, and we need to guide our teams on how to do it. Today I was in the room doing operative dentistry, and my whole team was mobilizing, taking a salivary sample, photographs, and risk modifier form, and and I'll come back and have a consultation with the patient about a treatment program. And it's really, really a nice way to practice.
Yeah, Doug, I think that's a really, really good point. Like, if you took all this information in today for the first time, it would be overwhelming. Yeah. And I think the thing to understand is that you didn't get to where you're at in your practice overnight. You've been at this literally, you've been on this pathway. I've known you for 20 years. Yep. And the same in my practice in terms of treating dental caries. I struggled for years trying to get that whole philosophy and that mindset into my team. And it's really takes your entire team to make that happen. But it's a years long. I mean, in your same thing in your practice, this isn't going to happen overnight, but you need to pick one thing, and start with that. And then then once you've got that accomplished, pick the next thing. And I'm going to try this, and I'm going to incorporate that. I tell you, Doug, your Wellness Dentistry Network, website with all the information there, my team, that helped us so much during our team meetings. We'd sit and go through one of the modules, and that was absolutely invaluable.
Thank
So
you.
I commend you
Yeah,
on that, Doug.
but I do agree, and that was a good point, Kim, about just taking time, and it just takes time. And I haven't gotten here overnight, and neither of you. So I want to make sure the viewing audience understands that we just want to show some possibilities, and we can guide people along one step at a time.
Well, and I think that the most important part is to take the first step, because if you don't take the first step, you never will get there, right?
Right.
So you need to, pick something and get your team, rallied around it and start with that, and then progress from there, and understand it's going to take some time. And actually, as Doug, as time goes on, 10 years from now, we'll know so much more than we know now.
Sure.
That you'll be changing this protocol. And so it's a growing and learning experience along the way.
And that's the idea by being affiliated with something that's dynamic, that's moving. It's not a single time and space. But I will tell you the other thing, Kim, because of the biofilm mediated diseases, there's only two: caries and periodontal disease. And I think we should become, and our hygiene team should become, master clinicians at treating that, because we can help so many people. And this disease is so undertreated that it's a great opportunity.
And Doug, if you don't have a healthy mouth, whether it's caries or periodontal disease, you cannot have a healthy body. And just what we know now about the influence that periodontal disease and these pathogens cause on other diseases, 57, I think you mentioned.
Yeah.
And I was reading even this week that if you have periodontal disease, it's a risk factor for death if you get COVID.
COVID, for sure.
Right. And
Yep.
so it's like that whole connection between the mouth and the rest of the body with these diseases. We're going to learn there's more and more that we don't know yet in terms of how important that is.
For sure.
So,
and this whole modulatory thing is something that's really going to get looked at a lot harder too. Targeted molecules, all kinds of different things are going to come along. And so I want to help be the source of how to productively and efficiently apply those into a clinical setting, so that we can, it's not just in a laboratory, but it's got to work in a clinical setting.
Yeah, exactly. Hey, Doug, so we've got time to take like a couple, maybe two questions.
Yeah, if you want. Yep.
Yeah, we had so many questions come in. Thank you, Dr. Thompson, for all of that information. So let me just jump into one really quickly. One question we received was about setting patient expectations. How do you, Dr. Thompson, identify treatment timelines with your patients, and how do you set up their expectations? How do you do that for them?
Yeah, well, it's a good question. And, staging and grading the disease, staging allows us to determine the disease severity and the disease complexity. And so we first off have to stage and grade the disease. When you have cancer, the first thing you ask them is, what stage is it? How hard is it going to be to treat? And so what I look at is the microbial profile, and then I look at the history. How old is the patient? Because age is a risk factor. And then I go through that risk modifier sheet. And that risk modifier sheet, it's taken years to put together, of the things that influence the disease. And so, and patients get it. They understand, if you have this microbial insult and you have these other modifying factors, this is going to be hard to treat. Now, I have the benefit of knowing, and if you're on this webinar, you could be safe to know. I heard a guy who said it takes 4.5 months to get get his patient stable. I'm working hard at it. I would never tell a patient that in 8 weeks they're going to be done. You'll have a few that might be stable, but you're going to have many that won't be stable. So just from today's experience, just say, I heard it might take longer. This could take longer, and somebody has to pay for that. So the other thing we do is we don't present a la carte treatment. We present a disinfection package. You pay me this much money, I'm going to have my team give you 6 appointments, and we're going to expect you to be well at the end. And we'll provide everything you need and nothing you don't to get you there. That's the idea. And there's going to be, 5 to 8 to maybe 10% of your patients you're going to struggle with, but the rest of them, you're going to hit a home run with a lot of them. And so that's the idea. So timeline, risk modification, bacteria profile, and then of course your treatment, what you do in treatment is going to make a big impact on what the outcome is.
Excellent, excellent. Thank you so much. And I think we have time for maybe one more quickly. We had a lot of questions come in asking your opinion of Arrestin. Could you speak to that quickly?
Yeah, it's a minocycline time. I call that a time release antibiotic. It's a minocycline sphere. And I think that it does, I used it in the beginning in all pockets over 5. Now I start to use it more judiciously at the first reeval. But I think that it helps. My personal opinion is I think it helps with inflammation reduction. I don't know that there's any clinically significant clinical attachment gain, but it's an adjunct. It's an adjunct. It does have a high carrying cost. It's easy to place. So out of the adjunctive antimicrobials, I think it's great. What I don't think you should do is I don't think you should spot treat patients with Arrestin. I mean, this is a mouth disease. It's not a localized disease, and these bacteria roam around. So I would think about taking a more comprehensive approach. Believe me, I used to do it, but I would take a much more comprehensive approach at treatment. We should be treating these cases in stage 1 and early stage 2. We should not be waiting until they get so advanced where you need all the sophisticated stuff.
Doug, you bring up a really good point there. I just want to ask you one quick question and then we can wrap. So you're talking about these bugs live everywhere in the mouth, and if you just spot treat, even if you're doing scaling root planing on half the mouth and the other half isn't treated, without the antibiotics, systemic antibiotics, I mean, these bugs are going to repopulate the area that you just treated. How soon? What's the time frame in between, or do you scale and do SRP in the entire mouth at one appointment? Or
it's a great question, Kim, and I know where it's going. Yeah, we try to do as much as we can in one appointment. It's a 3.5-hour appointment. We try to do as much as we can. The patients prepay for it. We really want that to happen that way. But let's say you had to split it up. If you had to split it up, the goal would be keep the appointments as tight together as you can, even in a week or maybe 2 weeks. But what you do, if you're going to prescribe systemic antibiotics, you prescribe the antibiotics and you start them on the day you scale the last quadrant or the last half of the mouth, and you must revisit the prior quadrants and do a refined fine scale on all those prior quadrants. You have to have mechanical disruption, chemotherapeutic irrigation, and systemic antibiotic use all at the same time. It's not going to make sense to start it at the beginning. You got to do it on the last day of the last scaling root planing.
Thank you, Doug. I mean, I think that was probably a lot of people are wondering that. And I would just say your results speak for themselves, Doug. So I applaud you on what you've done and where you're going. And I'm proud to call you my friend. And thank you so much for being with us today.
I'm the same. Kim, I just want to know for our listening audience, what will happen with the questions? I'm happy to, if you send me some stuff, I'm happy to answer questions. I'll help in some way because I don't want to leave people hanging.
Hi,
Yes.
Dr. Thompson. Yeah, that is excellent. Sorry to interrupt, but I was just going to let you know that the Q&A, we've been collecting all of the questions, and so we'll be sending them to you both to get your input on them, and then we'll include that as part of an email that we send to everyone that has registered. So they
I don't have anything to do next week, Jenny, so that'll be great.
There were only just a few questions too.
Yeah. Let's just hope you have electricity so you can,
Oh my gosh. Yeah.
Some of those
Yes.
questions too might be answered instead of my typing. I might make a audio recording. So I'm sure you guys can figure out a way
reference. Oh, for sure.
Yeah, definitely. So just to wrap things up, thank you everyone that is still on listening. Thank you so much for attending, and thank you to Dr. Thompson for taking time out of your day today, as well as Dr. Kutsch. So appreciate the information and the presentation that you shared with us. Again, afterwards, we're going to send out an email to all those that registered with a link to the recording. I know that's always a big question. The Q&A that we just talked about, and information about our next webinar in March, so you won't want to miss that. And then just a quick plug, don't forget to follow the CariFree Cooperative on Facebook, Instagram, and LinkedIn. We had the information on the slide there so that we can keep you up to date on what our great members like Doug Thompson are up to. There's a lot of helpful information there posted weekly, so check it out. And again, thank you everyone. Thank you, Dr. Thompson, Dr. Kutsch, Sharon, and Aaron, and Laura. Thank you so much.
Love you guys. Thank you.
Okay.
Yeah, everyone stay safe out there.
Yep. Be safe and be healthy. Bye-bye.
Yes.
Bye now.
Hi, everyone. Sorry, Sharon with CE Zoom. The code is up on the screen, but for those who cannot see it, Leslie, I see your question. The verification code is the COOP 50. THECOOP 50. And take that code, go to your CE Zoom account, log in, and next to this course, you'll see a green verify button, and that's where you'll enter that code. And for, again, that is the COOP 50. I've put it in the chat, and it's up on the screen right now, but I know a lot of you are listening and don't have video. And if you have any questions or if you need additional help, please visit support.cezoom.com, and we are happy to help you. You'll have to take a quick survey after your verification code. Give great feedback. This is an amazing presentation, and there were so many of you here today. Thank you for taking time out of your day for being here. The CariFree Cooperative always does such an amazing job with these webinars. Everyone have a wonderful day. Texas, the South, Louisiana, Mississippi, I hope you guys are doing great, and hopefully you'll get power back. And I think it's supposed to be 70 degrees next week. Everyone have a wonderful day. Thank you.